Doctors have a specific name for it. They call it xerostomia. And I promise you, that clinical term does not come close to capturing what it actually feels like. You know the experience. You open your eyes in the morning, and your tongue is stuck to the roof of your mouth. Your lips are cracked at the corners. Your throat feels like it's been coated in dust. And before you do anything else, before you check your phone, before you put your feet on the floor, you reach for water. And then the thought follows immediately. I must have slept with my mouth open. Didn't drink enough yesterday. Nothing serious. I want to spend the next several minutes dismantling that assumption entirely. For people over 60, waking up with a dry mouth is one of the most frequently dismissed signals the body sends. And in the vast majority of cases, it is not about how you slept. It is not about the weather. It is pointing to something deeper, something that deserves your attention and a specific, structured plan of action. Here is what I want you to picture. 7 days from now, you wake up and your mouth feels normal, moist, comfortable. You don't immediately lunge for the glass on the nightstand like you're crawling out of a desert. Your breath is cleaner. Your lips aren't cracked. You feel, genuinely, like you actually rested. That outcome is entirely achievable once you understand what is driving the problem and you address the right cause with the right action. But before we go any further, I need to flag something I'm going to return to near the end of this video. There is a specific combination of factors that makes morning dry mouth significantly more dangerous than most people realize. Not just uncomfortable, actually dangerous. For your teeth, your gums, and for processes happening deeper inside the body. I'll explain exactly what that combination looks like, but first I need you to understand the 5 causes, because the compounding effect only makes sense once you've seen each piece clearly. My name is Dr. Kevin Adewale. I've worked in internal medicine for over 2 decades, with a particular focus on healthy aging in men and women over 50. And dry mouth is something that comes up in my consultations almost every week, not because it's exotic or rare, but because it is so common that people have stopped treating it as a problem worth addressing. They adapt to it. They carry water bottles everywhere. They wake up miserable every single morning and consider it simply part of getting older. That ends today. Let's work through each cause methodically. The science, what it means for your body, and the concrete action that follows from it. Cause number 1, your medications. This is the cause that genuinely surprises people the most. You've been taking your blood pressure medication for years, your allergy tablet every morning. Maybe a low-dose antidepressant, something for an overactive bladder, a sleep aid, a mild muscle relaxant for your back. These feel routine, managed, not worth examining too closely. But here's what the research consistently shows. Over 400 commonly prescribed medications list dry mouth as a documented side effect. 400. That includes beta blockers and ACE inhibitors for blood pressure, first-generation antihistamines for allergies, tricyclic antidepressants and SSRIs for mood, anticholinergic drugs prescribed for bladder control, diuretics, muscle relaxants, certain medications used for Parkinson's disease, and several classes of pain management drugs. The mechanism is quite direct. Many of these medications interfere with the autonomic nervous system signals that instruct your salivary glands to produce saliva. Reduce that signal, and the glands slow down, sometimes dramatically. Think of it like turning down the volume on a speaker, except the speaker is your body's natural moisture production system, and you've been living with the volume stuck at 30% for years without realizing that's not how it's supposed to sound. And here is the statistic that should concern anyone over 60 who takes more than one medication. When you combine 2 or more drugs that each carry dry mouth as a side effect, the risk of experiencing significant salivary reduction doesn't add up arithmetically. It multiplies. Studies show that risk increases by 63% when multiple such medications are taken concurrently. The person taking 1 blood pressure pill and 1 antihistamine is not in the same position as the person taking neither. And someone managing 4 or 5 conditions simultaneously, which is not unusual at 65 or 70, may be in a fundamentally different situation without anyone having ever pointed this out to them. Your action here is simple, and it costs nothing. Sit down tonight and write out every single medication, supplement, and over-the-counter product you take regularly. Every bottle. Then bring that list to your doctor and ask one specific question. Could any of these be contributing to reduced saliva production while I sleep? In many cases, a timing adjustment alone makes a significant difference. Taking a medication in the morning rather than at night, for example, means the peak drying effect occurs while you're awake and actively drinking fluids, not while you're sleeping for 8 hours with your mouth closed and nothing incoming. In other cases, a functionally equivalent alternative exists with fewer salivary side effects. Your doctor will know, but you will not get that conversation unless you initiate it. Quick question before we move forward. How many of the medications you currently take have you actually looked up the full side effect profile for? Write a number in the comments below. I'm asking genuinely, not rhetorically, because someone else watching this tonight might see your response and realize they should check their own cabinet. That kind of thing happens more than you think. Cause number 2, sleep apnea. Sleep apnea is a condition in which breathing repeatedly stops during sleep. Sometimes for 10 seconds, sometimes for 20 or 30, sometimes longer. When the airway is obstructed, your body compensates by shifting to mouth breathing. And when you spend 6, 7, 8 hours breathing through your mouth, the mucous membranes lining it lose moisture at a substantial rate. You wake up completely desiccated, with that familiar sensation of having left your mouth open in a windstorm all night. That's the direct connection to dry mouth. But I want to stay on this cause for an extra moment because there is a larger picture that matters considerably. Sleep apnea is associated with substantially elevated risk of stroke, hypertension, and coronary artery disease. This is not a minor inconvenience about snoring. It is a genuine cardiovascular risk factor, a serious one. When dry mouth is caused by sleep apnea, the dryness is not the primary problem. It is the signal that something is interrupting your breathing, repeatedly, throughout every night. Here is how to assess whether this might be relevant to you. Does your partner describe your snoring as loud or irregular, with abrupt pauses followed by a gasping sound? Have you been told, even once, that you seem to stop breathing during sleep? Do you wake some mornings with a headache that disappears within an hour of getting up? Do you feel genuinely exhausted after 9 hours in bed, as though the sleep accomplished nothing? If 2 or more of those resonate, speak with your doctor about a sleep study. Home-based versions are now widely available and quite accurate. You wear a compact device in your own bedroom that measures oxygen saturation, airflow, and breathing patterns throughout the night. A specialist reviews the data and gives you a clear picture of whether apnea is present and how severe it is. If it's confirmed, treatment, most commonly a CPAP device that maintains gentle positive pressure in the airway during sleep, addresses the obstruction directly. It improves cardiovascular metrics, restores proper sleep architecture, eliminates the chronic mouth breathing, and in the process removes one of the most impactful drivers of morning dry mouth. One intervention, multiple meaningful outcomes. Cause number 3, blood sugar and what elevated glucose does to overnight hydration. When blood sugar is persistently high, the kidneys work overtime, attempting to filter the excess glucose out of circulation. To do that effectively, they pull water from the body and use it to flush glucose through urine. So you urinate more frequently, lose more fluid, and every tissue in the body, including the salivary glands, operates in a state of chronic low-grade dehydration. The glands simply don't have the resources to produce saliva at normal levels. And through the night, as you sleep and lose additional moisture through breathing and mild perspiration, you wake up with almost nothing left in reserve. People with poorly managed blood sugar often describe waking up with severe dry mouth, alongside 2 other very specific symptoms: intense thirst immediately on waking, and the need to urinate once or more during the night. If those 3 things are occurring together, that pattern is recognizable, and it calls for a blood test, not a larger glass of water on the nightstand. Here is what concerns me most about this particular cause. Type 2 diabetes can develop gradually, over the course of several years, with symptoms so mild and so easily misattributed to aging that the diagnosis is delayed far longer than it should be. Mild fatigue that reads like you're simply getting older. Slightly blurred vision on certain days. Thirst that feels a little more persistent than usual. Dry mouth every morning. None of these in isolation raises an alarm. Together, they form a coherent picture that warrants investigation. I've had patients in their late 60s who had attributed their dry mouth and nighttime thirst to drinking too much tea in the afternoon. When we ran the blood work, their glycated hemoglobin was well above the diagnostic threshold. They had been living with uncontrolled blood sugar for an estimated 2 to 3 years without knowing it. 2 years of silent damage to blood vessels, kidneys, and nerves, while they adjusted their pillow and bought a bigger water bottle. Your action is straightforward. At your next blood draw, request an HbA1c test specifically. This marker reflects your average blood sugar over the preceding 2 to 3 months and does not require fasting. If your result comes back above 5.7%, that is not a diagnosis, but it is a data point that changes the nature of your next conversation with your physician. It tells you which direction to look. Information is not frightening. Chronic ignorance is far more costly. Cause number 4, chronic dehydration. And the reason you may not feel thirsty even when you're significantly underhydrated. This is one of the most important findings in age-related physiology, and it is almost never addressed in a standard 10-minute clinical appointment outside of geriatric specialties. As we age, the mechanism that generates the sensation of thirst becomes less sensitive. In a younger person, a drop of just 1% in total body water triggers a noticeable, uncomfortable thirst signal. In someone over 65, that threshold is substantially blunted. You can be meaningfully dehydrated and feel no urge to drink at all. Your body is no longer reliably signaling its own need. Consider what that means in practice across a typical day. You go about your morning, you don't feel particularly thirsty. You have your coffee, maybe a glass of water with lunch, something at dinner. By evening, you've consumed perhaps 4 glasses of fluid total. You sleep for 8 hours without drinking anything, and you wake up with that dry, coated sandpaper feeling in your mouth, which you attribute to the fan in the room or the season rather than to the sustained, quiet underhydration your body has been carrying for the past 12 to 14 hours. The solution requires deliberate structure, not intuition, because with a blunted thirst response, how you feel simply cannot be trusted to guide your fluid intake accurately. You need a system that operates independently of the signal that's no longer working. Start each morning with 2 full glasses of water before your first coffee. Keep a glass on the nightstand and take several sips before you even stand up. If you need external reminders, set a quiet phone alert for mid-morning and mid-afternoon. The goal is 6 to 8 glasses distributed across the day, not consumed in a rush in the evening when your kidneys have already started winding down their overnight processing. One specific recommendation I make to almost every patient dealing with persistent dry mouth: use a mouth rinse containing xylitol before bed, not an alcohol-based rinse. This matters. Alcohol-based mouthwashes, including several of the most commercially familiar brands, are actively drying to the mucous membranes. They compound the problem they appear to be addressing. Xylitol-based formulas do the opposite. They stimulate salivary gland activity and leave a protective coating that persists through the early hours of sleep. The difference between waking with mild dryness versus severe, uncomfortable, sleep-disrupting dryness can sometimes be traced entirely to this one 30-second habit. Also worth noting, large amounts of coffee, regular alcohol consumption, and caffeinated sodas all produce a diuretic effect, meaning they increase fluid output beyond what they contribute. If these are consistent parts of your daily routine, they are quietly working against your hydration every single day. Cause number 5, and this one is more prevalent in people over 60 than most general practitioners acknowledge: Sjogren's syndrome. Sjogren's syndrome is an autoimmune condition in which the immune system mistakenly targets the body's own glandular tissue. Specifically, the primary targets are the salivary glands and the lacrimal glands, which produce tears. The result is persistent, often progressively worsening dry mouth, combined with chronically dry, irritated eyes. Both together, both ongoing, both frequently dismissed for years. Sjogren's most commonly develops in women between the ages of 50 and 65, though men are affected as well. Across both groups, it is significantly underdiagnosed. Because the onset is gradual and the symptoms closely resemble what people expect from aging, diagnosis is often delayed by years, sometimes by a decade or more. People adapt. They carry eye drops. They sip water constantly. They wake up dried out every morning and assume this is simply the texture of getting older. But there is a clinically meaningful distinction between the dryness that comes from natural age-related changes in glandular activity and the dryness that results from an immune system that is actively, persistently, and progressively dismantling the function of your moisture-producing glands. The first levels off, the second continues, and the long-term consequences for oral health, dental integrity, and quality of life are quite different. If your dry mouth has been present for months rather than occasionally, if you also experience dry or irritated eyes, difficulty swallowing dry foods like crackers or bread without water, persistent dryness in your throat or nasal passages, or more frequent dental problems than you would otherwise expect. Sjogren's syndrome belongs on the list of diagnoses to rule out before you attribute everything to aging. The diagnostic test is a blood panel checking for specific autoantibodies called anti-SSA and anti-SSB. A positive result doesn't merely explain the symptoms. It opens access to prescription medications that can stimulate residual salivary gland function, specialist rheumatology care, and targeted management strategies that substantially improve day-to-day comfort while protecting your oral and ocular health over the long term. That is a very different outcome from continuing to adapt. I'd like to ask you something before we move forward. Of those 5 causes, which one resonates with you most? Is there one where you thought, yes, that one might actually be me? Leave it in the comments. I read them, and knowing which causes connect most strongly with people watching helps me decide what to explore in more depth in future content. Now let me come back to what I mentioned at the very beginning. In clinical practice, persistent morning dry mouth is almost never caused by a single isolated factor. In more than half the cases I see, at least 2 of these causes are operating simultaneously. A patient taking 2 medications with documented salivary side effects, who also has mild untreated sleep apnea, and who is chronically underhydrated, experiences a compounding effect. Each factor amplifies the others. The medications reduce glandular output. The apnea drives mouth breathing through the night. The underhydration removes whatever moisture buffer might otherwise have cushioned the result. The outcome is not additive, it multiplies. And here is the downstream consequence that most people never connect to their dry mouth until the damage is already accumulated. Saliva is not simply moisture. Saliva contains antimicrobial proteins that actively suppress the bacterial populations responsible for tooth decay and gum disease. It contains enzymes that regulate oral pH, keeping it in the range where enamel stays intact. It contains remineralizing compounds that repair microscopic surface damage throughout the day. When saliva production drops significantly and stays low over months and years, decay rates accelerate. Gum tissue deteriorates faster. Oral infections become more frequent. And there is growing evidence connecting chronic oral inflammation, the kind that sustained dry mouth produces, to elevated systemic inflammatory markers, with implications that extend well beyond the mouth, into cardiovascular and metabolic health. So if you have been treating this as a minor inconvenience, a simple discomfort to push through in the morning, I want you to understand clearly. Xerostomia is a clinical condition with real downstream consequences for your body, and it is entirely manageable once you identify the correct driver and apply the right action to it. One final and important point before the protocol. If your dry mouth is accompanied by white patches anywhere inside the mouth, significant pain, or a persistent burning sensation on the tongue or cheeks, or sudden unexplained weight loss, do not manage this at home. Do not try a new mouthwash. These symptoms together fall outside the typical presentation of xerostomia, and they require prompt clinical evaluation. Schedule an appointment this week. Here is your 5-step protocol. These are not general recommendations. Each one is something you can begin this week. Step 1. Complete a full medication audit. Write out everything you take, including over-the-counter products, supplements, and sleep aids. Bring that list to your doctor and ask specifically whether any of these medications are documented to reduce salivary output. Ask about timing adjustments and whether therapeutically equivalent alternatives with fewer salivary side effects exist. Step 2. Assess your sleep honestly. Loud or irregular snoring, morning headaches that fade within an hour of waking, feeling unrefreshed after a full night, a partner who has noticed pauses in your breathing. If 2 or more of those apply, ask your doctor about a home sleep study. The conversation itself costs nothing. Step 3. Request an HbA1c test at your next blood draw. Know your blood sugar picture over the past 3 months. If you haven't had this measured recently, ask for it specifically. If the result is above 5.7%, use it to open a direct conversation. Step 4. Build a deliberate hydration structure that does not rely on thirst. 2 full glasses of water before your morning coffee. Consistent intake on a schedule throughout the day. A xylitol-based mouth rinse before bed. Alcohol-based mouthwash out of the cabinet entirely. Step 5. If your dry mouth has been persistent for several months, particularly if it occurs alongside dry eyes or difficulty swallowing dry foods, Ask your doctor specifically to check anti-SSA and anti-SSB antibodies. Those are the exact terms. Write them down if you need to. Here is the one thing I want you to do before this video ends. Open your medicine cabinet right now, or pull out your medication list if you keep one, and count how many products you currently take regularly. Then pick any two of them, just two, and look up whether dry mouth appears in the documented side effects. That single step, done in the next 10 minutes, gives you something specific and concrete to bring to your next appointment. That is not a small thing. That is precisely how a conversation worth having begins. If this gave you a clearer understanding of something your body has been signaling every morning, click the like button. It helps other people dealing with the same thing find this content. And for a condition this widespread and this consistently dismissed, that matters in a real way. I've also made a full video specifically on sleep apnea and its connection to cardiovascular risk in people over 60. If cause number 2 sounded familiar today, if any part of that description reminded you of your own sleep, that video is the logical next step. The link is in the description below. Your body communicates through signals. Some are loud and impossible to ignore. Others are quiet, persistent, and easy to explain away morning after morning. Until the morning you finally decide to listen more carefully. Dry mouth is one of the quiet ones. Now you know what it might be saying. Take care of yourself. I'll see you in the next one.